Hello,
Subscribe.
future doctors, and welcome to today's High Yield Explainer. If you have ever found yourself staring at a textbook, just trying to memorize those endless arrows of the coagulation cascade, well, you are in exactly the right place. Today, we're completely decoding the platelet and clotting cascades for your NEET PG prep. We're going to break down the complex pathways, those high-yield numbers, and of course, the clinical traps that examiners just love to test you on.
So chalo, let's look at our game plan. We'll be covering platelet basics, the thrombopoiesis journey, primary hemostasis, the clotting cascade, and finally fibrinolysis and coagulation tests. Let's jump right in.
Starting off with Section 1, Platelet Basics and Transfusions. Okay, let's nail down these baseline figures first. A normal platelet count sits anywhere between 1.5 to 4 lakh per microliter. Now, in the human body, a platelet lives for about 10 days. But dhyan dena yahan, this is a major exam catch. While the normal lifespan is 10 days in vivo, stored blood platelets only survive for a maximum of 72 hours. That is exactly why blood banks are constantly in need of fresh platelets. Now, technically speaking, thrombocytopenia is anything less than 1 lakh. However, actual clinical bleeding usually doesn't start until the count drops below 20,000, and spontaneous, life-threatening significant bleeding, that happens when it crashes below 10,000.
Now, here is a classic lab investigation trap for you. Imagine you order a CBC, and the lab reports a dangerously low platelet count. But you look at the patient, and the patient is perfectly fine. So what happened? Agar aap EDTA use kiya, to clumping ho jayegi. You see, the EDTA anticoagulant causes platelets to clump around white blood cells. This is an artifact known as platelet satellitism. The automated machine basically counts these massive clumps as single white blood cells, which gives you a falsely low platelet count, or pseudo-thrombocytopenia. So always remember the solution. To get an accurate count in these specific patients, you have to draw the blood using a 3.2% trisodium citrate tube.
Moving on to the wards, let's talk platelet transfusions. First golden rule, a platelet transfusion must be completed within 20 minutes. Now, you tabled it, co. We've got single donor platelets via apheresis and random donor platelets via pooling. STP is obviously costly, while RDP is cheap and widely used. But look at the clinical impact. One single expensive unit of STP gives the exact same boost, an increase of 30,000 to 50,000 platelets, as pooling together 4 to 6 entire units of RDP. Seriously, 1 unit of RDP only bumps the count up by a measly 6,000.
Let's move to Section 2, Formation, the Thrombopoiesis Journey. अब आते हैं इनकी origin story पर, tracking the birth of a platelet. Everything kicks off with the common myeloid stem cell that matures into a megakaryoblast and then into the massive megakaryocyte. Now here's a fascinating biological quirk for you. The megakaryocyte undergoes endomitosis. Basically, this means it multiplies its DNA, going from basophilic stages to having a multi-lobed pycnotic nucleus, but the cell itself never actually divides. It just gets bigger and bigger, packing itself full of granules. Finally, it extends these long cytoplasmic precursor extensions right into the bone marrow sinusoids, breaking off tiny fragments. And those fragments? Those are your circulating platelets.
But listen, this whole factory doesn't just run on its own. It needs chemical drivers. The early stage of thrombopoiesis relies heavily on thrombopoietin, which is primarily produced in the liver along with interleukin-3 for development. And yet, बहुत important point at coming up, it also strictly requires IL-11. Clinically, we actually use recombinant IL-11, which goes by the name oprelefkin, as a critical treatment for patients suffering from chemotherapy-induced thrombocytopenia. Meanwhile, the late stage, the actual shedding of the platelets, requires a totally different driver called STF1. Now, pathologists absolutely love to look at the shape of these megakaryocytes in the bone marrow. Seedha visual MCQ aata hai yahan se. You have to be able to match the morphological shape to the disease. If you see giant megakaryocytes, instantly think immune thrombocytopenic purpura, or ITP. Dwarf megakaryocytes? That's a classic hallmark of chronic myeloid leukemia, CML. If they literally look like fluffy clouds, that points you straight to primary myelofibrosis. And if they have this branching, staghorn-like appearance, your diagnosis is essential thrombocytosis. Make sure you lock these image associations into your memory.
Section 3, Primary Hemostasis, the Platelet Cascade.
So now that we have our circulating platelets, what actually happens when a blood vessel gets cut? This brings us to the formation of our first plug. But before a single platelet can do anything, you have to understand the golden rule of the endothelium. Concept ka samjho. Our intact blood vessels are naturally coated with anti-clotting agents. A perfectly healthy endothelium constantly releases prostacyclin, or PGI2, and nitric oxide to actively repel platelets. Therefore, for a clot to even start forming, endothelial injury is absolutely mandatory. It's only when the endothelium is torn away that the highly prothrombotic subendothelium gets exposed to the bloodstream. Step 1 of this cascade is adhesion, getting the platelets to stick to the wall. The second that injury occurs, von Willebrand factor, or VWF, gets released from the Weibel-Palade bodies of the endothelium and from megakaryocytes. This VWF acts like a biological bridge, connecting the exposed subendothelium tightly to the platelet's GP-IB9X receptor. At the exact same time, the platelet uses its GP6 receptors to bind directly to the exposed tissue collagen. Bam! The platelet is now firmly anchored. Once they're firmly attached, these platelets get angry. They activate, they change shape, and that triggers step 2, degranulation. Platelets carry 2 main types of granules. Alpha granules contain the larger proteins, but the really critical ones for a cascade are the dense or delta granules. Remember that dense granules release massive amounts of ADP? ADP is basically the ultimate SOS signal screaming into the bloodstream, calling all available platelets to the injury site. They also release calcium, histamine, and serotonin to kick the clotting process into high gear. And that SOS signal leads us straight into the final phase, aggregation. All those newly arriving platelets need a way to stick together. That's where fibrinogen circulating in the blood steps in, acting like molecular glue. It cross-links all the platelets by binding to the GPIB3A receptors present on every single one of them. This massive clumping forms our primary hemostatic plug. The bleeding stops momentarily. But listen, this plug is weak. It's temporary. It desperately needs reinforcement. Which brings us to Section 4, the clotting cascade, simplified. Enter the reinforcements of secondary platelet, the dreaded clotting cascade. It's essentially 2 starting roads that merge into one. Let's look at the first road, the intrinsic pathway, which typically represents contact activation in vitro. Honestly, it's just a simple countdown. It starts with factor 12 being activated by high molecular weight kininogen and kallikrein. 12 activates 11, 11 activates 9. Then, factor 9A joins hands with factor 8, along with calcium and a phospholipid surface. Together, this powerful complex activates the crucial factor 10, 12, 11, 9, 8, aiming straight for 10. But in the human body, following a real injury, the extrinsic pathway is the primary initiator, and let me tell you, it is much faster. In vivo, massive endothelial injury causes the release of thromboplastin, also known as tissue factor or factor 3. This tissue factor immediately grabs and activates factor 7. And what does activated factor 7 do? Boom! It directively activates factor 10. So you have 2 completely different pathways, both racing to do one thing: activate factor 10. Because factor 10 is the grand meeting point. This is where the common cascade begins. Activated factor 10 pairs up with factor 5, calcium, and phospholipase. This team takes prothrombin, which is factor 2, and converts it into the absolute superstar enzyme, thrombin. Thrombin is the master builder here. It takes that soluble fibrinogen from our primary platelet plug and weaves it into an incredibly tough, insoluble fibrin mesh. Finally, factor 13 comes in like cement to stabilize this whole fibrin clot. The breach is permanently sealed. But wait a second. What stops this cascade from just turning all your blood into solid jelly? Our body doesn't want to clot endlessly, right? So we have built-in checkpoints, our natural anticoagulants. Heparin-like molecules on the endothelium bind to antithrombin 3 to heavily inactivate factors 2, 9, 10, 11, and 12. Then you have thrombomodulin, which binds to rogue thrombin, changing its function entirely so it activates protein C, which then goes and destroys factors 5 and 8. And finally, TFPI, the tissue factor pathway inhibitor, shuts down the extrinsic pathway by inactivating factors 7 and 10. Brilliant system, isn't it? And finally, Section 5, fibrinolysis and coagulation tests. Let's fast forward a bit. The tissue beneath the clot has completely repaired itself. Now, that massive fibrin mesh is just in the way, blocking normal blood flow. So once the vessel heals, the cleanup crew arrives. Fibrinolysis is simply the process of breaking down that old clot. The newly healed endothelium slowly releases tissue plasminogen activator, or TPA. TPA seeks out plasminogen trapped inside the clot and converts it into active plasmin. Plasmin acts essentially like a pair of biological scissors. It brutally chops up that tough fibrin mesh into tiny, harmless pieces called fibrin degradation products, or FDPs, which simply get cleared from the blood. However, just like clotting, clot breakdown needs strict regulation.
Exam में पूछते हैं, which agents prevent clot breakdown? These are your antifibrinolytics, and they effectively promote thrombosis by stopping that cleanup crew from working too early. Remember these names: alpha-2 antiplasmin, thrombin activatable fibrinolysis inhibitor, or TAFI, plasminogen activator inhibitor, or PAI, and lipoprotein A. These ensure the clot doesn't dissolve before the tissue underneath is fully 100% healed.
So how do we actually monitor this entire complex system in a real patient? We use two main lab tests. APTT measures the longer, intrinsic pathway, as well as the common cascade. PT, or prothrombin time, measures the shorter, extrinsic pathway and the common cascade. Always remember it like this: APT for the inside road, PT for the outside road.
Let's end this with a clinical application to test those newly cleared concepts. If a patient का APT prolonged है, but PT normal है, which specific cascade is defective? Think about it. If the PT is normal, that means the extrinsic pathway and the common pathway are working perfectly fine. Therefore, by simple elimination, the defect has to be strictly isolated within the intrinsic pathway. But here's a thought-provoking question to leave you with today. What if both your PT and APT are severely prolonged? Which specific factors, or which common ward medications, could cause that double failure? Think about it, keep revising, and you're going to totally ace this on exam day. Thanks for joining me for this explainer, future doctor.